Hello, I am Omar Escondrillas, Senior Vice President of Equity Research and Programs at the National Health Council. Here at the National Health Council, our mission is to amplify the voices of 160 million people living with chronic diseases and disabilities, along with their family and caregivers. With the support of more than 170 national health organizations and businesses, we work to expand access to high quality, affordable, and equitable and sustainable healthcare. Today, we're here to talk about these critical issues in healthcare. Conditions like heart disease, diabetes, and obesity affect historically underrepresented and marginalized communities more severely. Our panel of leaders are here to explore the factors driving the higher risk of chronic diseases in these communities and to identify strategies to reduce disparities while improving long-term health outcomes. With me today is Anita Sathe, Chair of Case Management and Diabetes Prevention Program Coach at the South Asian Heart Center. We're also joined by Caleb Sneed, a public health practitioner dedicated to improving health outcomes in rural communities across Georgia. And finally, I'd like to introduce Armando Peña. He's an assistant professor in the Department of Health and Wellness Design at the Indiana University School of Public Health in Bloomington. So thank you all so much for being here with me today. Caleb, how do you define chronic diseases within your own lens as a public health practitioner?
Yeah, so we normally describe them as long-term health conditions that oftentimes need lifestyle changes and ongoing medical attention. So we often like to talk about things like risk factors, and for our purposes, those are just things that increase your likelihood of developing a chronic disease. And we like to point to healthy lifestyles such as having physical activity, having diets that's rich in nutrients. So we really want to target those types of interventions and lifestyle changes to decrease people's risk for developing those chronic conditions.
Thank you so much. And Armando, taking a little bit step forward with chronic conditions, specifically as you've been working in type 2 diabetes space, but why are certain communities affected more than others for chronic conditions like obesity, heart disease, and diabetes?
Yeah, really interesting question. So, you know, a lot of it I think is the social determinants of health. And so when we think about social determinants of health, we think about things like food insecurity, housing instability, transportation limitations, financial strain, diaper insecurity. You know, we can go on and on with the list of social risk factors. And so those are definitely things that we need to address and driving factors around the disparities. And then the other thing I think about is the cultural factors. So there's lots of cultural factors depending on what population you're talking about. But those cultural norms really do drive the behaviors of families because they run across generations. So we really think about these social and cultural factors that really drive some of these risk factors for these diseases.
Anita, from your experiences, what are those most significant barriers and life factors among underrepresented and marginalized communities that you work with? So can you explain a little bit more specifically heart disease, diabetes, and obesity? Please tell us a little bit.
It's more heart disease and diabetes prevalent in South Asian community. And it's a little bit lack of awareness. It's kind of, sometimes the attitude is, if it ain't broken, why fix it? Like a prevention. I'm talking about prevention angle. So when I'm not there yet, so then I can go on with my life as is. Do I really need to change? And behavior changes are really hard. It takes time, and you need to put in that time to make the behavior changes. It's also in South Asian community, we see that wives often are ready to enroll the husband in the program, for the lifestyle program we have. And they say, oh, he's the one who needs it. But in reality, anybody over age 18 can really start working on the lifestyle, and there are enough studies done, long-term studies done, that show that if you make changes in your lifestyle, as Caleb pointed out, in diet, exercise, meditation, and sleep, 4 aspects of lifestyle, then if you don't have a disease, you can prevent it. And even if you have been diagnosed with diabetes or heart disease, at least you will halt the progress of the disease.
So Caleb, I wanted to jump a little bit forward. Is access to healthcare is a well-known barrier for many, specifically with underrepresented and marginalized groups. So from your own perspectives and working in these settings, what are some of those local effective ways that hospitals, community centers, and even safety net services can support patients and caregivers in overcoming these access barriers that they often face, specifically for diabetes, heart disease, and obesity?
Yeah, it's a really good question. And a lot of hospitals have to do what we call community health needs assessments. And those are just as it sounds, you assess the needs of your community. But the second piece of that is not only are we supposed to assess the needs, but we're supposed to have a plan to deal with a lot of the things that come from that assessment. So as community health centers, as hospitals, I do challenge you not only to assess those needs, but to also be able to partner with other organizations, whether they're in your community or in our case, I'm a student and researcher at the University of Georgia, be able to partner with those organizations that do have the expertise to solve a lot of the problems that you identified in your needs assessment.
So I wanted to talk to you a little bit more about policy. What role does policy reform play in reducing healthcare access barriers?
So one thing that I would like to see is our health districts working together. We have health districts that are divvied up by region, and they don't always talk to each other. There's not always a table that is set for everyone to come to the table. Maybe this county has a primary care physician that's really great, but he's not accessible in another county. But this other county might have a OBGYN that this other county doesn't have. So having those relationships between different regions would really help counties and communities that don't have the resources that others do.
Talk to me a little bit more too about partnerships. What do you see yourself as sustaining valuable partnerships, specifically to address chronic conditions in underserved areas?
Yeah, so I work with a lot of Black churches in rural communities, and one thing that I really try to do is find that gatekeeper. Find the person in that community that has their hands in a lot of different pots. And what that does is it allows you to get into doors that you would not have gotten into just being a researcher or just being a practitioner. I live in Athens. I can't expect to go down to X county in South Georgia and say, I have all these things, I'm this, I'm that, because that doesn't resonate with a lot of different communities. So we want to make sure that we're finding not only trusted voices here, but trusted voices out in the communities that we're working with.
Anita, I'll go back to you. You shared some numbers of risk factors, specifically with heart disease in the South Asian community. Can you share the unique challenges, though, that occurs within the South Asian community? And I'll go a little bit forward, too, is how does your work help to address those challenges within the South Asian community?
So they come in, we first talk to them and get to know them well, their personal health history, family health history, as well as all their eating habits, exercise habit, meditation, sleep. And then they do the blood work, and then we work with them based on the set of recommendations that are created for them. They have an appointment with a health educator, and then the coaches work with them, and there are also live webinars for them to attend to learn about the topic. And the way we have implemented it is we work with them on really baby step goals. And it's not our goals for them, it's what they want to do. We start with that, they set up goals, we ask them what is your vision 1 year out, and we slowly work towards their vision. And we celebrate their success as every coaching appointment, a monthly or bi-monthly coaching appointment. When they come in and they say, they are very happy to share that, oh, I'm able to do this and I feel great.
Caleb, going back to Georgia.
Okay.
Going back
to
the Peach State.
Yes.
Because of the overwhelming amount of counties and rurality that exists in Georgia, can you share some of those challenges that exist within the Georgia rural communities?
Yes. So one of the things that we see a lot is barriers to reaching programs. So even if we're doing this diabetes prevention program in rural Georgia, some people say, I can't get childcare, or I don't have transportation to get there. So even if they want to participate, there are still barriers in place that prohibit them from participating in our programs. So one of the things that we've tried to do is implement telehealth hubs in a lot of our churches. And we have a screen, there are weight scales and other things in there to where even if I can't go all the way to another town, or even if I can't go to a hospital setting, I go to this church at least once a week. So if we can implement something within the church where I'm already going, that's a space where I can get the healthcare and resources that I need to prevent anything from Alzheimer's disease to diabetes.
Are there any particular cultural or faith-based considerations to help build that trust and engagement in the community? So
yes.
Tell our audience what has worked.
Go eat the barbecue. One of my mentors, she loves using this term. We go down, we go have a conversation. We don't just go down and talk about the data. We don't just go down and talk about the programs. Go to a church service. Go to the restaurant where they like to talk and just talk about anything. It doesn't have to be the program. And what that does is it creates a bond. And that bond is so important because what we're doing is very personal. Like, we're talking about chronic diseases. I work in Alzheimer's disease and diabetes and heart disease. Those are really, really hard topics to talk about. And it's especially hard when you're coming in as an insider, or as an outsider, and you're not trying to build actual relationships with those communities.
How do you work with caregivers, Caleb, to help address health equity in chronic diseases? Can you share the importance of caregivers, specifically also with faith-based communities?
So we always say, you're able to be the best caregiver that you can be when you are healthy yourself. A lot of our caregivers, they have chronic diseases themselves. A lot of our caregivers, they have depression and anxiety themselves, and that hinders your ability to be the best caregiver that you can be. We all know that you're busy, you have a lot of responsibilities. A lot of our caregivers have full-time jobs themselves, and being a caregiver is a full-time job in itself. So understanding that our caregivers need to help themselves before they can really give out the caregiving and the care that they want to give for their loved ones.
Armando, can you tell us about the root causes of type 2 diabetes among the Latino community? How does your work address these barriers to improve health outcomes?
A really good question. So, it's very complex, but essentially the answer is that it's a combination between biology and behavior, right? But in terms of the root causes of the disparities, that's a lot of what Caleb and Anita have already alluded to, which are these social risk factors, right? We think about needs for food, transportation, again, all these things that we've been talking about. Those really are the root causes of the disparity, and that's a key distinction to make is, the root cause of the disparity versus the root cause of the disease. And so in order to address those disparities, we need interventions that are innovative, at least compared to the status quo of interventions that we've tested in the past. There's a term that we have in our world which we call patient work, right? And that's the work that a patient has to go through day in and day out beyond the clinic, right? The clinic, physicians are stressed, you get maybe 5 to 10 minutes with them, then you're out of there. What do you do after that, right? You're in your house, you're at the grocery store potentially, you're in the community. And so these interventions need to happen in the community, especially when we're talking about prevention. And so in terms of these opportunities, we need health systems to be able to partner with these community organizations that are there, ready, and willing to serve. It's just we need better integration.
To wrap all this up, thank you again, first of all, to all of you. But I think one of the key messages that really resonate, it's about cultural congruency, making sure that we meet the communities where they're at, making sure that engaging non-traditional partners like faith-based organizations or safety net or another programs within health systems to help us identify how best to reach the community, and understanding that education is power, but it's how you deliver the education and who delivers the education is also very critical. Thank you for dedicating your time and sharing your perspective with us. And to our audience, thank you for tuning in. We encourage you to take this knowledge, share it with your loved ones, and inspire action in your own communities. Empower yourselves, advocate for change, and always consult with your healthcare provider to develop a personalized plan that best supports your health and well-being. Thank you.